Hello, everybody. This is the recording, and I'm recording it today, which is the second for October 3rd, the Friday where I'll be out of town. And effectively, we're going to do a bones introduction. Uh, there was one last item, and since I'm doing this for all of the classes, some have already had this information. But at the very end of chapter 3, at the very end of that PowerPoint sequence 3D, where it looked at the cell cycle, understand the only thing you really have to know about apoptosis or autophagy or any of those events that effectively that's the method that cells destroy themselves or are destroyed when there are when they don't reach whatever the chemical criteria are that allows them to survive and complete mitosis. And very often it's a self-destruct mechanism that's built in. The one that you should be the most familiar with is apoptosis, apoptosis, which is known as programmed cell death. Effectively, the lysosomes explode, releasing all those nasty enzymes and chemical agents and acidity that basically destroy the cell itself. Some people call it autophagy because eventually it's almost as though uh, the cell is almost gobbling itself up. There's other terms that are used for it, autolysis. It doesn't matter. Just understand the one that I use when I refer to it on test question is apoptosis. And that's really the last little nugget that I didn't quite get to in all the classes out of the interest of time, completing that chapter 3 material. I have put together here, and I'll show you now, the Welsh Hole PowerPoint. This is for skeletal. This one's pretty useful. In general, I don't love their PowerPoints. Again, you're going to see some similar illustrations, but it's not bad, and I'll marry that with some of the ones, and I will send you and this I can load, I suspect, directly onto Blackboard under what we're going to call Unit 2, or I've already identified as Unit 2, and then I'll be also sending you Chapter 6A and PowerPoints rather, 6A and 6B, which have additional information on the same topic from the Marib series that I like to use as well. So this is where we start. I know that you have already had a bones practical. So I'm eminently familiar with that. It doesn't mean that you can't, that basically identifies some general knowledge about bones and specific about features about bones, identifying the name of the bone, the specific features, little openings, things like that. All well and good. This is more, pardon me, on the physiology of bone itself. So effectively, just like any other tissue, bone is an organ. Okay. It's comprised of multiple tissues. You're going to see the outer lining called periosteum is dense irregular connective tissue. That's a tissue. Bone itself is a tissue, another type of connective tissue. And so effectively, it meets the test of being an organ. And so there's a lot of tissues, as you can see here. It has bone. It has areas in it that are cartilage, particularly when it's forming or on the ends of the bone. The dense connective tissue, both regular and irregular, and of course, blood vessels and nerves. And if there's one thing that describes bone to a T, it has a unbelievably good blood supply. That's what really sets it apart in my mind, as opposed to any other kind of a tissue. That's it, and that's the beauty of bone, because bone will heal. As long as when bones are damaged, if bones are broken, if bones are operated on, if bones have a defect, as long as you can put them together and hold them in place without an excessive amount of motion, there's just an extraordinarily good blood supply. And so that really is sort of the magical thing about bone. Bone to me is as magical and as interesting as any organ that you have in the body, and particularly the system of bone, the skeletal system, uh, as any that there is. And you'll see all the things that it does, and it's a lot more than people think. So clearly, this interesting tissue, some of it's very obvious. Support and protection of a variety of different things. Important things are encased in bone. Your skull encases your brain. as well as all the special sensory organs, are housed within a variety of bony areas. Some fairly large, like the orbit, some relatively small, like we're in the inner ear, inside the temporal bone that you learned about in laboratory. That's there. And whenever you see a bony enclosure, like the rib cage, or uh, I'm sure you learned about in the sphenoid bone called the sella turcica, where the pituitary sits. Those are all. Anytime you see a bony enclosure, something important sitting in there. Movement. I mean, effectively, muscles create the movement, but for the muscles to move and actually make us move around, we have to have something for them to attach to create that motion, and obviously that's the bone. Within the bone marrow, all, big word, all of your blood cells are formed. Red blood cells, white blood cells, platelets, which are the fragments of blood cells that facilitate blood clotting, all of those are formed within the bone marrow itself. And so, effectively, that, and you're going to learn that has a fancy name that's associated with it. And there's a whole chapter on blood in AP2. It's called hematopoiesis. So that means blood formation. So even though that really is sort of the overlap of the circulatory system with bone, it doesn't make bone any less important. Even you right now, you and I as adults, or effectively are what we would consider to be an adult skeleton, our bone formation, our big part, our blood cell formation continues to go on in any number of areas of bones. The big areas would be your sternum, the iliac crest. You remember the hip bone, the upper portion, that has a substantial amount of available bone marrow to do so, as well as the upper portions of the hip and shoulder assembly. That's where the greatest amount of bone marrow is in the adult. You understand, as we sort of move along with it, that what we call red bone marrow, the interior bone marrow that's everywhere in growing bones, replaced as we become adults by yellow bone marrow. And what some authors, and hopefully not this one, start talking about the bone stores fat. It really doesn't. Your bone marrow becomes yellow bone marrow is a fatty bone marrow that happens in adult bone. If you want to consider it storing fat, but if you lose weight, you're not going to lose your bone marrow. It's just a transition. And sometimes when the system requires it, some of that bone marrow, that yellow bone marrow, can actually transition back to red. But that's a whole other lecture that's going on. So blood cell formation, right after its blood supply, right after these things, blood cell formation and movement and structural support, absolutely mineral storage. It is a bank. And it's a bank for a particularly important cation, positively charged ion called calcium. Calcium with a +2 charge. If nothing else, okay, calcium is everywhere. Calcium makes nerves function, makes muscles function, makes blood clot. It's integral. Integral. It's integral in all of these processes. You're going to get sick and tired of seeing calcium levels. They are just so terribly important. We store all that calcium in bone. Okay. The vast, vast majority of the calcium that we have is stored in bone. At any one time, we probably have a rather substantial amount of calcium moving around in our systems. Okay. And so when we need, and if the calcium levels begin to, so it's maintained homeostatically by negative feedback in a range of roughly 8.5 to 10.5 milligrams per 100 milliliters of blood. That's a normal you get used to when you work inside of a hospital, 8.5 to 10.5. Understand that we are constantly adjusting it. As we need more calcium, we pull it out. Where do we pull it out of? Bone. When we have a little extra calcium from something we ingested, okay, because we haven't had to use quite as much of it as was anticipated, we put it back into bone. It's like you have a bank account. When you need money, you got a savings account. You got to need money, you got to pull it out, and if you have a little extra money, you put it back in. But you try to keep the balance around the same because you want to keep earning interest. That's kind of what happens with bone. You want to maintain that level in bone as consistently as possible, understanding that at times you're going to add in, you're going to pull it out, and times you're going to put it in. So mineral storage, a big player. Yeah, when we look at structurally, and I think that's more about lab, and maybe if you go into a biomechanics course, the types of things that it has. Lab is all about axial and appendicular. That's the way I would frame it. If I was teaching the bones lab, and I do with my advanced students, I'm sure you went into the different shapes. It's funny, size is less important than shape. Most of our discussion in this chapter is going to be about is going to relate to the long bone. That's the best way to understand the two portions of long bones, cortical and cancellous, to understand really how bone forms, where it gets its strength, what's its sort of the basis of its microscopic structure, why it's just so interesting to me. And indeed, we classify bones by their shape, not by their size. And I'm sure you went over this in lab. I mean, the femur is the longest and strongest bone in your body. It's a long bone. The little tip of your pinky, known as the distal phalanx, okay, is a long bone. It means it's longer than it was wide. That's all it means. And so we classify bones by their shape, and we classify bones by a variety of other things. And I'm sure you went over the four major categories. And so they all have similar structures, not identical structures, but similar structures. The development is very, very similar. There's really only two ways that bone develops. Bone, it develops from a cartilaginous shell, and that's nearly all of our bones, all of our extremity bones, okay, develop from a cartilaginous shell. It's made out of something called hyaline cartilage. There's different cartilages that I'm sure you learned about. There's elastic cartilage, which is only in two areas, in your ear and in your epiglottis, okay? That's the only two areas. Fibrocartilage makes up the intervertebral discs, makes up the pads we identify as the menisci in your knees, for example, the symphysis pubis. All of those are tougher, stronger cartilage, but the vast majority of your cartilage is called hyaline, Hyaline. All of your respiratory cartilage is hyaline cartilage, and not all of your bones, but the vast majority of your bones are hyaline cartilage. The bones in your skull, I suspect your clavicles, maybe your sternum, they all form by something called intramembranous bone formation. It's a little hard to explain. It's just like bone magically appears inside soft tissue layers and begins to form a particular type of bone that's there. So when we begin to understand how bone not only is assembled, but how it grows at growth plates, and that's part of what we look at in this chapter, that is that really involves that cartilaginous shells. And effectively what happens, if you want to simplify how bone cartilage becomes bone, it gets invaded by blood. Blood destroys cartilage. When you get blood into a joint, when you have a sports injury, auto accident, something happens at home and blood somehow gets into a joint, that blood immediately starts to erode the cartilage. Understand, when cartilage rather is replaced by bone, in any bone that moves, the very ends of those bones are still made out of hyaline cartilage. That allows the bones to move. It's smooth, white, glistening, and because of those smooth surfaces and their shapes allow us to flex and extend and abduct and adduct and rotate, and all the neat motions that bones and joints have are because of the cartilage that's there. Good news, bad news, blood begins to erode it. And any athlete that has had blood in a joint over time is going to develop something called post-traumatic arthritis. It might take 10 years, it might take 25 years, it may take 50 years. They may even not know they have it, but it will be there. So that's sort of the interesting thing, to get back to the original point. When you have cartilage, hyaline cartilage, what starts the deteriorating process is the start of a blood vessel entering it. Because remember, from learning about different kinds of tissues, cartilage doesn't have any blood supply. It's like epithelia. Okay, doesn't have any blood supply. So we're going to look at all of those different things that are there. Here are the different categorizations: long bones, longer than they're wide, expansile at the ends. Short bones, very interesting. Should have gone over this in lab. They have a very thin shell and a lot of bone marrow inside. Okay. And they're interesting in that regard. So we typically see them in the wrists and the ankles. uh, they don't, each one doesn't move a lot, but when we add up all their motions, we get the unique activity we have, let's say, in your wrist and in your ankles, the way we can move around those joints, which are made of multiple bones, very effectively. I'm sure they told you about sesamoid bones. They form in tendons or ligaments or other kinds of soft tissues, actually muscles and tendons classically. And the patella is a very good example of a sesamoid bone. On its internal surface, it is covered in cartilage, so it forms part of the knee joint. Externally, it's not. It's there. And flat bones, those are just, think of the skull, think of the sternum, think of the iliac crest. Okay, that is actually a variation of flat bone, and that's where we see the residual red bone marrow. Okay, that's there. When we have to evaluate bone marrow or do what's called a bone marrow aspiration, we get areas like that, particularly the sternum and the iliac crest. Basically, you can where you can feel on the side of your hips. That's there. That's a relatively easy area to access and effectively suck out a certain amount of bone marrow to see what's going on. Why would we do that? Well, most importantly, to determine why someone is anemic. And also, or and is that what's going on in the bone marrow specifically, and to rule out things like leukemia, which is effectively a cancer of the bone marrow. Okay, and irregular bones are just that. They don't, they're not. Their uniqueness is that there's no other bones that are like it, and the vertebrae bones are always like that. So those are the classic examples they can show you. I'm sure you saw that before in lab. Kind of neat. And so when we start talking about the one we wanted to talk about the most is the long bone. And again, you start by effectively it has a shaft and ends. So the shaft, famous name for the shaft is diaphysis. The famous name for the bones is the epiphysis or epiphyses. And typically, you don't say upper and lower. You typically say proximal and distal. Okay, that's typically the way that you refer to those things. You might say medial and lateral if that's the appropriate case. So you use anatomical directional terms. When I was talking about circulation, the circulation enters, oops, I'm ahead of myself. The circulation enters the diaphysis in the shaft. It's really important. Surgically, we look at that because you want to make sure you know where the main blood supply is entering the bone, so you don't inadvertently, if you don't plan what you're doing surgically, cut off that circulation and cause part of that bone potentially to die. The ends that develop afterwards, later, okay, after the bone starts to develop in the middle of the shaft, are called the epiphyses, plural, epiphysis, singular. Okay, heads and bases. Some people will talk about it. It's whatever language there is. And there's a very interesting area called the metaphysis. Meta means beyond. Okay, and so it's between the diaphysis and the epiphysis. It's beyond one of those physes, hence the name metaphysis. And it's a kind of an interesting area because it's a transitional zone that kind of has both strength and a lot of blood supply. So it's got a nice combination of hard outer bone and inner, what we call cancellous or spongy bone. That's a very good area to work on. Okay, when you have to do things to bone because it's strong enough to heal and yet it has a lot of circulation comparatively to help it heal. Again, it starts as cartilage. I have a visitor of the canine variety. It starts as cartilage. And the cartilage that's left at the very ends of the bones, and you're going to go over that again when we look at joints, is called the articular cartilage. Again, when we talk about articular, something articulating, it means it joins another bone. Those skeleton, the skeleta, the plural that you have in the laboratory, the ones that are all hanging up, that's called an articulated skeleton. It's in this case, it's wired together. So an articulation is where two bones come together. Whether or not they move depends on the nature of the joint. To me, the most important piece of tissue is the sheath that surrounds the bone. It's not delicate, it's strong. It's called periosteum. It's really what something called perichondrium, which means around the cartilage, comes from. It's dense, irregular connective tissue, strong. Not as thick as the deep dermis, but strong like the deep dermis. It's a very, very strong fibrous membrane on the outside, and on the interior, it has layers and layers of bone forming cells that are there. And it's the pivotal piece that allows bone to remodel, it allows fractures to heal, it maintains the vitality, the ability of the bone to flourish under a variety of conditions that are there. It's so terribly important when we operate on bone and have to work on bone, whether we're fixing a fracture, whether we're taking out a piece of bone, to reset a bone or to change the angle of a bone, all of those kinds of things. We're very careful to preserve that periosteum. It's from that into those openings, if it's a fracture or a surgical or an operative site, a surgical site, where the tiny cells migrate in, they move into and start laying down new bone. So the periosteum is really significant. It's dense, again, irregular connective tissue, surrounds the bones, and other than the areas where it makes a transition where the bone moves at a joint, where it becomes what's called the capsule. It's really an extension of this, except it's similar but different in the sense of the lining inside the capsules makes the fluid that bathes the joint called joint fluid or synovial fluid. Two types of bone, cancellous or cortical bone. I beg your pardon. Cancellous or cortical bone are the two types. Compact and cortical we use synonymously. They're in the outermost layer, particularly in the diaphysis. It's present but very, very thin in the epiphyses that are there. The epiphyses have it's almost like a shell in the epiphysis. And when you're talking about the diaphysis or the shaft, it's not a shell. It's a thick boundary. And you're going to see any number of illustrations of these from a variety of things we look at. We'll be looking down the road, we'll be looking at x-rays and fracture sites, and you can kind of get an idea of how thick the cortex is in certain areas. And that's the name we use. And so get used to the terms of cortex and medulla. Cortex means the outside of an organ or a structure. The medulla is the interior. So a lot of times you'll hear cortical bone or medullary bone. And the cavity inside the bone where the blood forms is called the medullary canal. And so it uses that term. The medulla is its internal portion of the cortex is outer. You're going to see that a lot. You're going to see it in kidney. You're going to see it in ovaries and testes. You're going to see it in a lot of terminology refers to the cortical area or the medullary area. When you see the term of trabeculi are the hallmark of spongy bone. It's not organized in the same classic way, and that's something I'm going to be doing in class, the organization of cortical bone. Okay, these are just plates, shelves and plates of bone that form a honeycomb. They're like underpinnings to provide strength. They're extraordinarily important, and more importantly than that, they provide a dramatic amount of surface area that allows for the red bone marrow and the lining to drape over them and provides an abundance of surface area for blood cell formation. And what happens, those underpinnings, when we use bone in a certain way, we develop more of them in certain areas that are under a lot of stress. And indeed, that's one of the things radiographically, which means under an x-ray, we look at to determine if someone's getting anything called a stress fracture, which are very, very common and pretty common in young people who are athletic or into sports or into a lot of physical activity. So sort of the interior, as you work your way from outside the bone, you have cortical bone. As you get further in, you have the cancellous bone and these hallmarks of trabeculi. And then as you get farther in, you have a cavity. It's called the medullary cavity. It's a hollow chamber, and that's where the marrow is. And I said it drapes over all that wonderful surface. It too is lined. Before you get to the red bone marrow being draped over it, there are areas where they have tiny thin layers of lining cells called endosteum. The endosteum also gives rise to bone precursor cells and certainly plays a role in healing and fractures, but not nearly as much as the periosteum. Most of what the bone heals more from the outside than from the inside. So the inside, it can be somewhat randomized and proceeds relatively slowly. The outside provides the strength, so to speak, when a bone is broken. And then you can see the red or yellow. Again, yellow if the bone has effectively stopped growing and stopped its role as blood formation, fills with yellow marrow until normally for the rest of your lifetime, and in rare instances where it may need to be utilized. Again, it's a pretty good illustration. Here's your femur, looking at it from posterior. Okay, so, and again, the metaphyseal areas, why that's important surgically. A lot of times, if we have to make cuts in bones, we use that because it has both strength on the outside and a lot of blood supply on the inside. For instance, this is what I was telling you about. We're very cognizant of this. Is called the nutrient artery, or the neurovascular bundle. And that's an area where you want to be careful not to cut around that because you could disrupt the blood supply. But here you can get an idea a little bit in that denser wide area of the thickness of cortical bone. They really don't give you a good look so much at the sponginess of the bone, but they're just using this kind of a pattern that I'm pointing to with the cursor. And here you can see yellow bone marrow. And here's the periosteum. The periosteum, again, it's quite thick. Comparatively speaking, you get a pretty good idea of the thickness. It's thick enough that you can cut it and size it, pull it off the sides the way it's sort of demonstrated here, and sew it back together, which is exactly what we do. And so you can see these types of things where you are either spongy bone and where the cartilage would be located right around this portion of the head. This white glistening area is the cartilage that is on these structures, which I'm sure you got in lab and learned were the femoral condyles. So you have the head, the neck, greater trochanter here, lesser trochanter here, etc., etc. And then subsequently, we're going to get into all these microscopic structures. The main cell, again, they all come from a common origin. When we make fibrous and connective tissue, we have fibrocytes. When we make cartilage, we have chondrocytes. When we make bone, we have osteocytes. They can kind of flip-flop. Okay. So you're going to see when bone heals, when it's broken, it forms what we call a fibro. It's like it's sort of like an accumulation of fibrocartilage that occurs in between the areas where it's broken. And eventually bone begins to develop in there as it begins to calcify and kind of form bone. Okay, so we call it a callus, fibrocartilaginous callus, and then finally a bony callus. Interestingly enough, okay, I said the cells, they can start as fibers, then they can change into cartilage, and then they can change into bone. What signals each of them to do that? That's certainly not clear. Again, one of the hallmarks that people will talk about endlessly, and I don't know why, are called lacunae. These are the chambers. Chamber's a good word. It's again, a lot of things we look at microscopically and say, aha, I know the cells in there, and there's some kind of chamber surrounded by, because there's a space between the cell and the walls. More or less, the fact is it doesn't stain when we look at it microscopically, or whatever type of visual, whatever type of scan or imaging technique. Just looks like there's a hollow area. It's not. The body doesn't like hollow areas. Okay, there's usually something in there. If it's some kind of fluid, it doesn't stain. Some kind of material, it doesn't stain. So it's sort of erroneous, but at least those quote unquote chambers is not a terrible word for it. That are there. And the osteocyte means they're mature. When we see the term osteoblast, okay, that means blast means it's busy. Cyte means it's just doing its regular job. Blast means it's in the process of remodeling bone. I've said it to every class. I'll say it a couple more times to you. The bones you have in your body now are not the bones you were born with, or the bones that you developed and matured as children. They've probably been replaced at least twice over by this time. You're constantly remodeling bone. And because of that, the bone changes from you might call it a resting stage, but it's not, it's still busy. The osteocyte into something called an osteoblast when it's in the active process of remodeling. And you'll learn about things called osteoclasts. CLAST means something's destructive, breaking something down. Okay, and osteoclasts are continually gobbling up bone, releasing calcium when it's needed, remodeling it based on pressures, if you go from a sit-down job to a busy stand-up job, etc., etc. We'll look at what the canaliculi is, because those bone cells, those osteocytes, communicate with each other, nutrients and waste products. We're going to look at what it's made up. The only fiber is collagen that's there. The collagen fibers are the fibers that are part of the matrix of bone. Remember, the matrix is ground substance and collagen fibers. The matrix consists, the collagen fibers, in addition to that, it consists of a calcium binding protein. And effectively that's part of the, remember, it's ground substance and fibers that make up the matrix. So collagen, dynamically strong, and the arrangement is very, very interesting. Okay. And what really gives it the final strength are all those wonderful inorganic salts, which are basically calcium phosphate, maybe some calcium carbonate, and magnesium phosphate. Calcium phosphate predominates. The fancy name we give to this, the way the crystals are arranged, you will see and read about, is called hydroxyapatite. Hydroxyapatite. It's a very unique way that they form. And so we're going to look further when we look at compact bone. We're going to spend time looking at the osteon, this very interesting arrangement. The osteon is the true structural unit of compact bone. Each osteon consists of a tiny pillar, like a dowel, like a small. If you go to Home Depot or Lowe's, you can get dowels, which are small wooden cylinders of relatively small diameters. Let's say a half an inch, 3/4 of an inch, and so and if you think, if you have those standing up, you could rest anything on them. This has multiple of these cylinders that are all held together. And that's this very unique thing. So the osteon are the individual cylinders, they're held together. I'm going to show you with some other illustrations the structure and the way the collagen is worn, is the way the collagen is wound around it, both clockwise and anti-clockwise, what we call counterclockwise. You're going to see layers. Each osteon, it looks like, it's almost like tree rings. And imagine the strength that it has, and something around what's called the central canal, which is a blood supply. So it's tremendously strong, resisting not only compression, but twisting and turning and bending. And the spongy bone, with these plates called trabeculi, imparts a certain amount of flexibility. Okay, remains strong, but doesn't weigh as much. If bone was completely solid through and through, it would make our moving them very, very difficult. And we'll see this as well. This is just some actual real views of it. These are, probably skeleton. And, whether or not this, certainly you can see this sort of honeycomb pattern. This is what this trabecular pattern looks like. That's so important. And a flat bone here. This would be like a skull. It probably is. You'd have spongy or cancellous bone in here, and you can see the thickness of the cortical bone. Okay. Here, let's say this is the head of anything. That would indicate a variety of, here you can see a relatively thin amount in the recartilage under here, and maybe just a teeny tiny amount of compact bone, just a vast, vast amount cancellous bone. And here you can get an idea. This would be the marrow cavity in the center, rather substantial compact bone, and then some spongy bone there. I'm going to stop it here, because this is really where I'm going to probably flip back to the other PowerPoint and start taking a look at all of these things and be able to describe them to you and give you an idea how strong they are. So thanks very much. It's a relatively brief presentation, but it'll cover everything for today. It's a good introduction to bone, and we'll go from there on Monday. Thank you very much. Have a great weekend, depending on when you listen to this. Bye-bye.